moderator, ladies and gentlemen, for giving me the opportunity to present my topic. I will present my topic of the influence of cleft lip and palate severity on surgical outcome. My name is Ruby Riana Asparini. I am from Department of Surgery, Faculty of Medicine, University of Muhammadiyah Malang. Cleft lip and palate malformation is remain the most prevalent congenital abnormality, with the annual incidence comprised 7,500 individual cleft lip malformation and accompanied by cleft palate. Assessment of surgical outcome based on severity provide feedback to the medical team, minimizing the occurrence of complications that may impact oral function, aesthetic appearance, nutritional intake, and speech development. The evaluation is with the cleft lip and palate severity is categorized into classification with mild and severe. The evaluation employs a measurement of ratio between cleft width and normal nostril width. It objectively determined through the nostril width ratio method. Mild severity is indicated by cleft width ratio less than 2, while the severe category encompasses a cleft width ratio exceeding 2. The post-surgery, the severity assessment outcome for unilateral cleft lip and palate is divided into 3 assessments: lip, nose, and palate outcome. These are respectively categorized as good, moderate, and poor outcome based on the visual chart. The good category show almost no visible cleft and fistula, so they are not require resurgery. The moderate category shows cleft asymmetry and fistula formation requiring minor reconstructive procedure. The poor category is described in the form of visible asymmetry and significant gap formation. Method study design. This is a retrospective method that utilizing medical record of Medical Faculty of Muhammadiyah University. The patient of unilateral cleft lip and palate is from 2019 and 2020 that underwent surgical intervention with 40 patients. The preoperative assessment is with nostril width ratio is ratio of nostril width of cleft side and nostril width of non-cleft side. Unilateral cleft lip and palate severity index evaluates the overall appearance of the primary deformity and separate patient into 2 categories. The mild is complete cleft lip that nostril width ratio of less than 2, and severe complete cleft lip that nostril width ratio is greater than 2. The visual rating chart that value of 1 and 2 is good, 3 is moderate, 4 and 5 is poor. We include 5 of evaluator within 40 sample that at least 6 months after the surgery. This is the result. We use the labioplasty procedure, utilize the Nordau surgical technique, while the palatoplasty procedure employed the von Langenbeck technique. When analyzing the data collected between 2019 and 2020 from the sample size of 14, it became apparent that assessment of severity of unilateral cleft lip and palate was concentrated primarily in the severe category. The severe category accounted for 2,002 cases, representing 55% of total, in contrast to mild category, which consisted of 18 cases, amounting to 45% of cases under investigation. Regarding the lip outcome, the majority of subjects, comprising 65.5% of cases, were categorized in the good category, indicating favorable results. A significant proportion at 22.5% fell into the moderate category, suggesting acceptable outcome. The poor category had the lowest representation of 15%, indicating that a smaller number of individuals had less favorable lip outcome. Move to the assessment of the nose. The data demonstrated that the good category was still the most frequent, with 42.5% of cases falling within the disfavorable outcome range. The moderate category accounted for 37.5% of cases, reflecting moderately positive results. The poor category, through less common, was represented by 20% of cases, signifying individuals with less favorable nose outcome. Finally, the palate assessment inhibit the highest frequency in the moderate category, encompassing 50% of cases. This suggests that a significant portion of individuals had satisfactory palate outcome. The good category accounted of 32.5% of cases, indicating positive results, while the poor category was the least common, with 70.5% of cases showing less favorable palate outcome. The inter-rater reliability among assessors was assessed using the ICC reliability test. The significance of lip and nose assessment yield value more than 0.8, signifying a robust and highly significant agreement among the evaluators. The significance of palate assessment displayed value more than 0.9, indicating an almost perfect agreement among the evaluators. The initial step involved conducting a chi-square correlation test to investigate the connection between the severity level of unilateral cleft lip and palate and the outcome of surgical procedure. Since the expected count value was greater than 20%, the analysis was continued with the use of non-parametric Mann-Whitney test. The Mann-Whitney test revealed that it's significant less than 0.05 for each surgical outcome, indicated a noble association between the severity of unilateral cleft lip and palate and the result of surgical procedure. Discussion. The results of this study showed that the incidence of cleft lip and palate unilateral weight category is more dominant than the mild category. This study relevant to several studies in Asia that the incidence of cleft lip and palate compare more often found. The utilization of ICC reliability tests involving the panel of 5 evaluators who meticulously examined 40 photographs effectively curtail subjectivity in evaluating surgical outcome. Labioplasty surgical outcome at mild severity resulted in the output of good category severity results that are very dominant. But there is an even distribution related to the severe severity. The study also revealed that mild cases will give better results. Skillful operator selection and selective implementation contribute to favorable outcome, with the nodal technique proving effective in restoration function, symmetry, and aesthetic. The outcome of lip surgery surpassed those of nose surgery in terms of percentage. This phenomenon is common in both bilateral and unilateral and bilateral cleft lip cases. palatoplasty surgery outcome demonstrated significant strength. This means that at mild severity, it will produce better surgical output than at severe severity. Notably, the outcome of palatoplasty exhibit a pronounced significance, suggesting that mild severity cases yielded superior surgical outcome in contrast to severe severity cases. The significance between severity and surgical outcome on the palate frequency hing on depth with surgeon proficiency, appropriate procedure selection, and surgical technique. The limitation of this topic is the study limitation include a retrospective design with a potential bias, focusing on single center, a 2-year analysis time frame, subjectivity in outcome assessment, reliance on the single operator, and accent of adjustment for confounding variable, limited follow-up duration, and scope limitation due to excluding speech development and patient satisfaction. This aspect call for careful interpretation, emphasizing potential gap and the need for broader research. The strength of this study lies on its approach to evaluating the relationship between cleft severity and surgical outcome in the comprehensive manner, covering lid, nose, and palate categories using standardized technique. This approach contributes to a deeper understanding of factors that influence surgical success in cleft lip and palpation. The study employed standardized surgical techniques encompassing nodal and non-von Langenbeck procedure, ensuring uniform treatment approach. The inclusion of substantial sample of 40 patients undergoing unilateral cleft lip and palate surgery enhanced the study robustness. The unique aspect of this study lies in its comprehensive evaluation of surgical outcome for cleft lip and palate patients, particularly those with unilateral cleft lip and palate. It differentiated itself from other studies by exploring the relationship between the severity of the cleft and surgical result, covering lip, nose, and palate categories. Conclusion of this study has significant value of less than 0.05 with non-parametric Mann-Whitney test. There is a positive correlation between the severity of unilateral cleft lip and palate with the output of surgery result. This correlation is rooted in the intricate dynamic of wound healing influenced by intrinsic factors. Thank you. Nothing is more beautiful than the smile that has struggled through the tears. Thank you, Dr. Asta.
First of all, thank you very much for the organizers for inviting me for this webinar. This rare case, we have found 2 cases in last 6 to 7 months, but out of the 2 cases, I am just focusing on the one which is much more important for me. So it's a case of secondary syphilis, nodulocystic variant. It's known as lues maligna. So it was coined by Bazin and Lubeck in the mid 1800s. So the cases that we saw, 2 of the cases were immunocompetent, but lues maligna is mostly seen in the immunocompromised patients, especially HIV positive. The lesions would be pleomorphic, mostly nodulocystic, and eventually lead to ulcerations. And I'll be showing you the lesions also. So it would be rupert, cross-state type of lesions, and the patient will have constitutional symptoms. So these are the rupert type of lesions in close. So while dealing with the diagnosis of lues maligna, we usually follow the Fisher's criteria. So in this, according to Fisher's, he says that all the 4 has to be present. But in our case, the Jaris Hersheimer.
Can you hear me?
Yes, doctor, we can hear you.
Okay, I'll see. Okay, there's a case of Louis maligna, a 38 years old female with multiple non-itchy nodules and ulcers over the body for 4 weeks, and fever, headache, and myalgia for 2 weeks. She had multiple sexual partners. Uh, and these are the photos. When she presented initially, she had a lot of, lesions, nodal ulcerative lesions over the body, face, chest, trunk, uh, for the limbs, upper limbs and lower limbs. But the lower limbs were much more swollen than the upper limbs. Then we admitted the patient and we investigated the patient. Routines were relatively normal, but the serology was, VDRL we did, it was 1:128. TPH was positive, HIV was negative. We also did MRI of brain and spine, it was normal. Echo was normal. Then on CSF examination, we did VDRL, it was 1:4 reactive. And usually in CSF, TPHA is negative. I don't know the reason why, but in blood it is positive, but in CSF when we examine, I asked my seniors and all also, they said like TPHA would be negative. And then biochemistry, we had little bit elevation of adenosine deaminase, LDH, and total protein. So we did histopathology, and on histopathology we found a lot of subepithelial and periadnexal plasmacytic and lymphocytic infiltrate, which was suggestive of secondary syphilis in our pathology department. We treated the patient with intramuscular benzathine penicillin, 2.4 million units on each buttocks, 1.2 in each buttocks. We did continued that for 3 weeks. And then we admitted the patient for 23 to 24 days until she got very well. So there was no reaction. And in Fisher's criteria, well, like I told before, it was compatible with gross and microscopic morphology. High titer of serology was there, VTRL. Reaction was not there, but there was dramatic response of antibiotic therapy. So, just as a conclusion, it's a very rare manifestation, and we are very happy when, this kind of cases we get to see. Although it is not good for the patient, but for us, we get excited with every rare cases. Most commonly, it was associated with HIV, but in our case, it is not. And so I just wanted to, conclude that we need to be aware of maligna also because of, increasing in syphilis and other STD problems.
Good afternoon, everyone. I'm Dr. Rohit Singla from India, and I'll be presenting a rare case of lepromatous leprosy who presented with central serous chorioretinopathy. Just a minute, I'll share the slides. Yeah, the slides are visible, right?
Yes, we can see them.
Okay. Just a second. I'm stopping. Okay, so this is a introduction. Leprosy, as we all know, is caused by Mycobacterium leprae, which is a gram-negative bacilli. It mainly affects skin as well as peripheral nerves. So ocular involvement in leprosy is estimated at the rate of 70 to 75% worldwide, and approximately about 10 to 50% of them suffer from severe ocular symptoms, whereas blindness occurs in 5% of the cases. So ocular involvement should not be taken lightly in such patients. The ocular derangements in leprosy patients include lagophthalmos, that is inability to close the eyelids, then keratitis, episcleritis, scleritis, and iridocyclitis. It it is extremely rare to see the posterior segment involvement in leprosy, as Mycobacterium leprae, it prefers the cooler temperature. So the anterior segment is more likely to be involved in cases of leprosy as compared to posterior segment of the eye. In literature, a rare association of retinochoroiditis and central serous chorioretinopathy is reported, but there are very few cases. So the purpose of this study was to report a case of rare association of CSCR in a patient of lepromatous leprosy who presented with type 2 reaction or ENL. Coming to case report, this was a 37-year-old male who complained of burning of vision associated with redness, watering, and photophobia in both the eyes. When he came to our OPD, he presented with multiple lesions, especially nodules over the face as well as extremities. The nodules which were present over the face were of lepromatous leprosy, and the nodules which were present over the extremities were transient in nature. So we made and patient also complained of a fever with joint pain that was recurrent from the past 20 days. On examination, he had loss of sensation over both hands as well as feet, and he also gave history of slippage of footwear. So a diagnosis of lepromatous leprosy with type 2 reaction, that is erythema nodosum leprosy, was made. His posterior ocular nerve was thickened and very much visible on both the sides, which is shown in pic also. And when the lesions of erythema nodosum leprosum healed, they left behind pigmentation, post-inflammatory hyperpigmentation over the legs, which is visible in the third photograph. So he also complained of eye symptoms, ocular symptoms, that were redness, watering, and photophobia. So the patient was referred to ophthalmology before beginning treatment. So so the best corrected visual acuity was in the right eye was 660, and in the left eye it was 636. On anterior segment examination, patient had partial medrosis over the lateral eyebrows. In right eye, he had superficial punctate keratitis. Okay, as it is not much visible in the figure, but on the cornea there were multiple minute dots. And anterior chamber was full of reaction. The cells were 4+, and there was a membrane formation which was plasmoid aqueous. And as you can see, pupil is deformed because of posterior synecdoche. Then there were pigments on the anterior lens capsule. The pigments can be seen. I have marked them with red arrows and the posterior synecdoche with blue arrow. In the left eye, as it is clearly visible in C figure, patient was not able to close his eyelids. So patient was suffering from lag of thalamus. Then he also had superficial punctate keratitis, and the reaction in anterior chamber was less as compared to the right eye. And pigments on the anterior lens capsule were present on both the eyes. Now, coming to fundus examination, as there was reaction in anterior chamber in right eye, so the view was very hazy in the right eye, and there was it was also due to presence of posterior synecdoche. Excuse me. And in the left eye, as it is clearly visible, there is collection of subretinal fluid at the level of macula. Okay, so behind the retina, there was collection of subretinal fluid. It was a little visible in the fundus examination, but when fundus fluorescein angiography was done, so in right eye, it showed hyperfluorescence, nasal to fovea, and in left eye, it was very clearly visible that there was ink blot leak sign. Okay, so whenever there is leakage from the vessels to the in between the retinal layers, so it appears as an ink blot sign, just like the ink on tissue paper, which confirmed that there is collection of the fluid in subretinal area. So as there was reaction and subretinal fluid accumulation, so diagnosis of bilateral anterior uveitis and central serous chorioretinopathy was made. So patient was advised by the ophthalmology department to use topical steroids in a tapering dose for the reaction part, then cycloplegics or dilators to prevent further posterior synechys, then lubricants for keratitis, and from dermatology side, MDT was of course continued. But as you know, the first line of treatment for management of erythema nodosum leprosum is steroids. But we could not give steroids to this patient because it could worsen the eye symptoms and it could worsen the CSCR, and patient could lead to we could lead the patient to blindness if we would have given oral steroids. So instead of steroids, methotrexate was chosen, and we started the patient on methotrexate weekly dose. And as the patient was in reaction, the dose of clofazimine was increased to 300 milligram per day, along with NSAID for the treatment of ENL. After 2 weeks, patients' erythema nodosum leprosum symptoms were improved, and as far as I was concerned, the reaction in the anterior chamber was resolved. So in fundus examination, it could be clearly visible where the fluid was collected in the right eye. Okay, as you can see here, the yellow arrow shows the collection of retinal fluid. In the left eye, it was at the level of macula. In optical coherence tomography, that is OCT, it is clearly visible. The red arrow shows the deposition of fibrin, and white arrow shows detachment of retina. Okay. And in the left eye, there is clear subretinal fluid collection at the level of macula. After 6 weeks of follow-up, right eye showed dissolved subretinal fluid and fibrin, and left eye also showed very minimal amount of subretinal fluid, okay, which was confirmed by OCT. Moving on to discussion. Ocular involvement in leprosy can be due to 2 factors, either direct infiltration by the Mycobacterium leprae or due to the immunological changes which happen in reactionary episodes. The paralysis of facial nerve or seventh nerve can give rise to the weakness of orbicularis muscle, leading to lagophthalmos as well as ectropion. In our case, it was lagophthalmos. In such patients, cornea may show superficial punctate opacities and interstitial keratitis, that is inflammation of cornea, particularly in the upper and outer quadrant. In some cases, minute nodules or pearls can also be seen on the surface of iris. Now, CSCR is an idiopathic disorder which is characterized by localized serous detachment of the neurosensory retina at the level of macula. It can lead to blurring of vision along with other eye symptoms. So the risk factors for CSCR include males with type A personality, emotional stress, then oral steroid intake, Cushing syndrome, and rarely it can be associated with leprosy. Now, in cases of erythema nodosum leprosum, as it is a type 3 hypersensitivity reaction, there is increased serum levels of TNF alpha, interleukin 6, and interferon gamma. These are the inflammatory cytokines. These are also found raised in CSCR patients. The interleukin 6, it increases the vascular permeability by inducing the increased expression of vascular endothelial growth factor. Vascular endothelial growth factor can increase choroidal vascular hyperpermeability and can increase choroidal hydrostatic pressure that overcomes the retinal pigment epithelium barrier function, ultimately leading to accumulation of subretinal fluid. Excuse me. So erythema nodosum leprosum is treated mainly with corticosteroids, and steroids are also used in ENL for extended periods of time because they have to be tapered very slowly to prevent further episodes of reaction. But the problem is, in our patient, we could not start it because CSCR worsens with systemic steroids and can lead to permanent damage of the retina. In order to avoid systemic steroids for the management of ENL, Alternative therapies include immunosuppressants, which are methotrexate, azathioprine, cyclosporin, and mycophenolate mofetil. Then anti-malarial drugs like chloroquine and clofazimine in higher doses, as we chose for this patient. Conclusion, this case highlights the association between CSCR and leprosy, and that's why it mandates the ocular examination in leprosy patients, especially when patient is giving history of any symptoms or signs. And management of such patients should be in such a way that we have to avoid the steroids use. Thank you. These are my references.
Should I repeat it from the beginning? Or it's fine? Summarize it. Okay, so we mentioned that the treatment of vitiligo should be personalized case per case, and we should include the parent with our treatment. So we should do good counseling for the parents before we start our treatment regarding the course of the disease, and we should discuss the prognostic factors for vitiligo that include the duration of the disease, the size, the extension of the vitiligo area, and if there's any hair involvement, as well as if there's any and what the skin type for the patient. Also, we should discuss with the patient the treatment options that include the availability of the treatment, the safety, and the efficacy, as well as we should consider the site of residency. For example, if you want to start phototherapy and the patient lives far away, the patient couldn't give us a home-based treatment. So this should be considered when we select our treatment. The other thing that we should consider also the cost of treatment as well as the patient preferences for the treatment. The patient always asks about the duration of treatment, for how long it lasts. So this thing also should be considered and discussed with the patient, and the regular follow-up and the best follow-up to do for the patient is by using photos. Let me know if you can see my slides now, please. So what's our goal of treatment? So our goal of treatment includes stabilization of the disease or repigmentation of the vitiligo. And in certain cases, we need to do repigmentation of the normal remaining skin. So things to consider when we start treatment and select our treatment. We should consider the type of vitiligo, which subtype of vitiligo the patient has. Is it segmental versus non-segmental? And also we should consider when we select our treatment, the activity of the disease. Is it active or stable? And again, what the patient preferences, cost, and accessibility for the treatment. So what is our approach? The patient has non-segmental vitiligo and he presented with a localized type of vitiligo of less than 10% of body surface area involved. So we now consider the combination of both topical corticosteroid that we usually start with super potent topical corticosteroid like clobetazole propionate that we give it on daily basis for at least 1 month. Then we decrease the potency and the frequency. Like for example, we can give mometasone fumarate on daily basis for the next month. And then we decrease the frequency, or we can give it alternating weeks, 2 weeks on and 2 weeks off to decrease side effect of steroid. This is given in combination with topical calcineurin inhibitor that we use tacrolimus 0.1% ointment. That is the one that we use on that we use twice daily. We consider examine light treatment and option for treatment. Then if the patient has non-segmental vitiligo, but now the area is more than 10% of the body involved. So this is generalized type of vitiligo. Then what is our approach? We start usually with narrowband UVB that is given 3 times per week with regular follow-up on monthly basis. And this is not given less than 6 months duration. And this is better to be given in combination with, because always combination is better than monotherapy. But in certain cases where there is a rapid progression of vitiligo, and so there's a large number of new spots that appear within the last 3 months, or there's a rapidly enlarging of pre-existing lesion within the past 3 months, now we should consider using systemic steroid like oral minibus therapy. In our hospital, we use dexamethasone orally on 2 consecutive days. We give either 2.5 to 5 milligram 2 consecutive days for around 6 weeks. Patients who presented with universal type of vitiligo where the body area involved more than 90%, now we consider depigmentation. Depigmentation by either using the monobenzyl 20% that is given twice daily for at least 1 year, or we can use certain type of laser like fused ruby laser, the one that we have in my hospital. For a patient who has segmental vitiligo, which this depends if the patient presents in the early phase and still active, or when it becomes stable. So if the patient presents within the early phase of segmental vitiligo and still active, we treat it as non-segmental vitiligo. So here we give both combination of topical corticosteroid and calcineurin inhibitor, as what we just mentioned in non-segmental. And in this condition also, we consider targeted phototherapy. Excimer light is a good option because this type of vitiligo is very difficult to treat when it becomes stable. So we know now about the memory cell. So the earlier you start, the better the response. Once the patient has or become stable and segmental, now again the options for targeted phototherapy, and the other option is using surgical methods or resurfacing laser in combination with topical for resistant stable cases. Now, our management and our protocol is consensus with the therapeutic algorithm that is followed worldwide. And this summarizes the algorithm for treatment. Now, let me share with you some of our institutional study at King Abdullah University Hospital. The first study is talking about the efficacy and safety of excimer lamp in combination with tacrolimus. So what is this study? This slide shows the aim and the material and method of the study. So what is the aim of our study is to assess the efficacy and safety of excimer lamp in combination with tacrolimus in children with limited vitiligo. Our population in this study were children. We included 50 children with limited vitiligo of body surface area of less than 10%. And the study was randomized controlled clinical trial. We divided the patients into 2 groups. Group A, who received both tacrolimus and excimer light, while Group B include who received only treated with tacrolimus ointment. Then we assessed the efficacy. The efficacy was assessed by assessing the repigmentation percentage of vitiligo area from the baseline, and this has been done at 3 points after 1, 3, and 6 months of treatment. And then we assessed the improvement. We divided the improvement into 5 groups. We consider the patient has excellent if their repigmentation area were from 76 to 100%, and moderate response if it is from 51 to 75%, and mild if it's from 26 to 50%, or minimal improvement from 1 to 25%, or no response. So what was our result? This figure shows the result of the treatment, as you can see, after 1, 3, and 6 months. If you can see this after 3 months, for example, you can see using both tacrolimus ointment and excimer light show improvement of 40%. Okay, repigmentation increased to 40% versus only 15% with tacrolimus group alone. And then with continuation of treatment after 6 months, the percentage of repigmentation increased in with tacrolimus and excimer light to 65% versus only 30% of tacrolimus group. So you can see now the superiority of adding excimer light to tacrolimus alone. Also, when we assess the excellent moderate mild response, we saw some patients with excellent response when we use combination of treatment. After 3 months, there was one patient showed excellent response versus 0 patients for tacrolimus group alone. And after 6 months, 22% of patients with combination of treatment, exam light and tacrolimus showed excellent response again versus 0 response, excellent response for tacrolimus alone. So it is not only get better improvement, but also the response rate also and the percentage of improvement is better. Okay. And of course, the treatment response differ according to the body site involved. As you can see here, the face is the better site to respond, while the hands and feet, they are the lowest site to respond. And this is as previous or all other studies. Face is the better place to respond. This is one of our patients who were on both tacrolimus and excimer light. As you can see around the eyes, he has dramatic improvement after 3 and 6 months. Also over his armpit, you can see the dramatic improvement after 3 months and excellent complete resolution of the lesion after 6 months of treatment. Another patient has pigmentation response differ according to different body sites. So this patient saw excellent response around his eyelid. This patient an excimer laser, excimer light with tacrolimus. Also, you can see over his anterior upper face, he has a dramatic response after 6 months of treatment, and over his trunk, you can see the significant response after 6 months. Another patient, you can see less response over the knees, as we mentioned, and the worst response is over the feet. This patient has very minimal response over the feet. This is another patient that we included in our study. As you can see over his forehead, after only 3 months of treatment, he has excellent response with complete resolution of his vitiligo area. So our conclusion for this study, the excimer light and tacrolimus has superiority over using tacrolimus ointment alone as monotherapy in children with limited vitiligo. The other study that we in my hospital was a comparison of the efficacy of tacrolimus ointment versus calcipotriol or betamethasone in combination with narrowband UVB in treatment of vitiligo. So what was this study? This study, the aim of the study was to assess the efficacy and safety of different topicals in combination with narrowband UVB. We compared tacrolimus and betamethasone, calcipotriol. So the participants were adult, 41 adult included, with generalized vitiligo of body surface area of more than 10%. This is again randomized controlled clinical trial. We divided the patient into 2 groups. Group D, who received narrowband UVB in combination with calcipotriol or betamethasone, and Group T, who received narrowband UVB in combination with tacrolimus. Then again, we assess repigmentation percentage of vitiligo area after 3 and 6 months, and we divided the improvement into 5 groups, as we just mentioned previously in the previous study. So this figure shows the result. As you can see, after 3 months, the improvement of calcipotriol betamethasone group was 35% versus 32% for tacrolimus group, and there was no significant differences between the 2 groups. The same were found in the after 6 months. As you can see, the improvement of calcipotriol group was 54% versus 45% in tacrolimus group. Again, there was no significant differences between the 2 groups. So both topicals show efficacy and safety in combination with narrowband UVB and patients with generalized vitiligo. Again, the response depends on the area involved. The better response over the face and the least over the hands and feet. This figure shows how the correlation between the duration of disease and the starting of treatment, the response to treatment. So the longer the duration of the disease, the better, the worse or the response. So with increasing the duration, the response decreases. This is one of the patients who were in calcipotriol group. You can see the improvement in combination with calcipotriol, betamethasone, with non-UVB. Another patient on both tacrolimus and non-band UVB, you can see the improvement with time, but again, treat is at the lowest response. Okay, and the third study was the comparison of efficacy of tacrolimus ointment and tacrolimus plus topical pseudocatalyst superoxide dismutase in children with limited vitiligo. Again, the aim of the study was to assess if there is any synergistic effect of adding superoxide dismutase to tacrolimus ointment. So our population of study were in this study with limited vitiligo of less than 10% body surface area involved. So again, it was a randomized controlled clinical trial that we divided the patients into two groups. Group 1 who received only tacrolimus, while Group 2 received tacrolimus in combination with pseudocatalyst superoxide dismutase. And again, we assess the efficacy assessed by assessing the pigmentation percentage of vitiligo area from the baseline. That has been done at 3 points after 3, 6, and 9 months. Again, we assessed the improvement. We divided the improvement into 5 groups, as just previously mentioned, to excellent, moderate, mild, minimal, or no response. So the finding was as follows. So the patient, after 3 months on tacrolimus group and tacrolimus plus superoxide dismutase, both almost the same response. You can see there's no differences between the two groups. And this was the same after 6 months and after 9 months with continuation of treatment. So as you can see, this figure shows the treatment response for both groups. You can see they all are almost the same. There was no difference between the two groups. So what were the summary of our results? So this is the final slide. I will summarize the results. So the first study showed that the combination of examined light and tacrolimus ointment has superiority over using tacrolimus ointment as monotherapy in children with limited vitiligo. So it has a benefit of adding examined light. The second conclusion, combination of narrowband UVB with tacrolimus ointment or with calcipotriol, betamethasone dipropionate, both are efficacious in treating generalized vitiligo in adults. And the third conclusion, the combination of topical pseudocatalyst and tacrolimus ointment has no superiority, no added value over using tacrolimus ointment as monotherapy in children with limited vitiligo. And thank you for your attention.
Yes, thank you for the introduction. I am Gail. I'm not a doctor. Let me go to my first. So just to give you a little bit of background on who I am, I'm actually a speech language therapist, and I will be discussing my involvement from when I was working at the specialist burns unit at Chris Hani Baragwanath Academic Hospital. I was there from 2012 until 2021. So this is a public hospital in Soweto, Johannesburg. During this time when I started working there, I assisted in establishing the speech therapy services within the adult burns unit, which is a 6 ICU, it has 6 ICU cubicles and 24 ward beds. And yeah, within this team, I work within a multidisciplinary team at the burns unit. So you might be wondering, okay, where does all of this fit into the whole bigger picture? So it's speech therapy is quite an emerging role within burns management. We play a large role. Let me just go to my next. Actually, I will come to my role a little bit later, but maybe just to give you a background in terms of the sort of population of burns patients in South Africa. What we do know is that burn injuries, if they are not fatal, can have very devastating and long-lasting consequences for both health as well as a person's functional capacity, and particularly for their aesthetics. Most of the burns patients that come in will have burns to a certain part of their body and then also their face. A lot of the time it's their face included, and this has quite a big implication for these patients. And we see that there are about 1 million people who are burnt each year in Africa. And of this, there's an estimated 45,000 deaths in South Africa alone from burn injuries. And it leaves a lot of patients permanently disabled. So what we see is the management of these burn injuries requires very timeous and specialized care from an entire multidisciplinary team of healthcare professionals. And unfortunately, in South Africa, being a developing country, it lacks a lot of within the public healthcare sector where I was working, it lacked a lot of the established infrastructure, including equipment and consumables that you need to adequately manage these kind of burn injuries. So then getting to my role as a speech therapist, I play quite an important role in prevention as well as treatment of oro-facial contractures post-burn injury. So although typically as speech therapists, we work with dysphagia, the swallowing disorders, the speech and voice and all of that, within this population as well, I'm going to be focusing more on my role in terms of oro-facial exercises and trying to prevent these contractures from occurring. So I'm sure you're all familiar with a contracture, but let me just give you a definition. According to Schouten, it is described as an impairment due to the replacement of skin by pathologic scar tissue that is resulting in reduced range of movement of an anatomical structure. So it obviously will happen anywhere, but I'm looking more at the facial burns. So in other words, we've got mature, thick, tight scars formed after sustaining either a partial or a full thickness burn, and these tighten and contract, which then limit the mobility of that area which is burnt. A contracture, if occurring on the face, can result in impaired ability to move one's mouth adequately in order to speak, to eat, as well as to achieve adequate facial expressions. During the time at the burns unit, I worked very closely with an occupational therapist who was involved in doing scar management. So the OT would often do the scar management in other areas of the body, maybe joints and things like that. And I did a lot of the scar management for the face. And I think what's very important is that timing is everything. So treatment starts immediately when the patient comes into the unit. And what we've seen is that reduction in range of movement can occur within 8 hours of the person being burnt. Not that it's a permanent contracture at that point, but already that range of movement is limited, which will affect swallowing, it will affect speech, and it's quite debilitating. So I have and my next slide has got some images of one of the patients that I treated. He had full thickness burns to his face, and he was already starting, so in spite of starting oro-facial exercises really, really early on, we can already see that the contractures were starting to develop. And the two pictures that I'm showing you, the one on the left is where he was just at rest. And then on the second picture, all I asked him to do was to open his mouth for me. And as he opened his mouth, because the skin was contracting on his cheek, you can see where the ectropion happens on the eye, pulling down the lower eyelid. So from an aesthetic point of view, as well as a functional point of view, you can see the importance of trying to manage these contractures for, just general facial expression and for function. So yeah, in spite of a lot of efforts, his burns, unfortunately, were very, very thickened. So it could have been a lot worse, but yeah, unfortunately, we couldn't stop that. But there is room for trying to improve that later on. And then if we look here, this is the same patient. You'll see on the left image where I've put an arrow, you'll see in the corner of the mouth, there's that thick band of skin that is contracting and preventing his mouth opening. It's also preventing, it's preventing the horizontal movement in the corners of the mouth. So you will see for him, he was unable to open his mouth to a full range, and we use these Therabite devices to try and measure the mouth opening, and he was also unable to smile as broadly as he would normally with before the burn injuries. But we were working on improving this as well. So this was just an image to show you how the contractures form in the face. So my role is obviously to try and prevent these and to work on it. So we do oro-facial management, and we try to increase the range of movement of these facial structures in two different ways. So the first one is to do passive stretches, and these often start as early as day one, and often the patients may be in ICU, they would be ventilated, they may not even be very much awake and alert, but already at that point, we start to do the passive stretches to get the movements going on the face so that by the time they're extubated and step down to a general ward, they're able to move their face well. Then we also do active exercises. That's actually the patient then participating and moving the different structures of the face. And then, as I mentioned already, after these process of passive and active exercises, we then start the scar massage together with the occupational therapist. So this is just an indication of some of the different exercises that we do for the face. So obviously we will customize it to the patient and where the burn is for them, whether it's the whole face or just half of the face. But we start with a variety of exercises that aim to get as the maximum range that they are able to achieve by actively moving their face. And then we obviously, where they're unable to achieve a certain movement actively, that is where then the passive range of movement stretches will come in. So these are just different exercises for the whole face, lips and mouth and cheek and eyes that we will target for the patient. Then we would also do the passive stretches. So here you will, show them how to do it themselves. We might do it for them initially, using a gloved hand or finger. We would just pull into the corners of the mouth, pull the lips forwards, lift the eyebrows up, or the various movements that they're unable to achieve. And then we would move on to the patient being able to do it independently. And we would do 5 sustained stretches for 30 seconds. And we encourage the patients to do it about 3 times per day. So this is them doing it passively. And then we also use some devices. This is called the Therabite device, which if the patient hasn't got too much burn injuries to their hands and they have hand function to be able to do this, we can actually measure. You'll see it's got a little measurement on the side, and we can look at even 1 or 2 millimeter increments or changes over time. So these are just some of the stretches that we try to do to improve the range of movement in the mouth so they're able to eat and smile and speak appropriately without any distortions in their speech. So everything was going well until along came COVID-19, which very much made my job particularly difficult to do these oro-facial exercises. So as you know, during this period of time, we required extensive use of PPE, It made it almost impossible for me to do the oro-facial exercises with the patients, and removal of the burn therapist's face mask in order to demonstrate the exercises puts both the patient and the therapist at increased risk. So this was quite a challenge. And so during this time, I came up with a solution. So the idea was to unmask the problem. And I created a series of short videos of various oro-facial exercises, as well as scar management techniques for the patient, which allowed the burns therapist to make use of technology as a medium of providing the most effective therapy possible. So each video, it was no more than just a few seconds long. And what made it so effective is that it was readily accessible to the burn therapist at any time. So it would be on my phone. I would create all of the videos. I would just take it out. Obviously, I would keep my PPE on in order to protect myself, and then the patient was able to view all of the different stretching exercises, the active exercises, as well as the massage things, and be able to see it well. So at this time, when I was doing this, the International Society for Burn Injuries invited burn therapists from around the world to describe innovations that they have created in order to solve burn rehabilitation problems. So each submission was then reviewed in a blinded manner by an expert panel of 3 independent rehabilitation therapists from the International Burn Society Committee. And these submissions were reviewed for originality, utility, quality, as well as safety, and then edited and compiled to be shared and disseminated throughout the world. So for this, there was a total of 77 innovations that were submitted for review, and 71 were accepted for publication, and given an opportunity to publish in the Burns Open Journal. There were clinicians from 15 countries that submitted innovations, and these were categorized into various different things like orthosis or scar management, different techniques of therapy activities, of daily living devices, educational tools, and prostheses. So this idea that I had was then submitted to this journal, and yeah, and it was very effective. So just to provide a description of how the innovation helped to overcome the challenge of COVID-19 was that safe demonstration of videos were available via a smartphone for 5 to 10 second. There were 5 to 10 second clips. As I said, they were very easily accessible from the therapist's pocket at any time. It continued the provision of effective treatment to the patient. So I was able to show them exactly on the screen how to do all of the exercises. And it allows for maintenance of, it allowed for maintenance of infection control measures. So I could keep my face mask and respirator and visor on throughout treatment. So at no point did any patient go without the appropriate treatment. And these videos, according to the patients, once we started implementing them, the patients actually reported that the videos were a lot easier to follow compared to the written handouts, which we used 2D illustrations. So you may recall the picture with the person's face showing all the different facial movements. That was originally how we used to give the ward exercise program to the patients, and they would try and follow the pictures, but they actually reported that the videos were a lot easier to follow. It also had the added benefit of being easily accessible, which meant that it could be disseminated to the patient as a home program when they were discharged from hospital. So we would use it during the ward to do the therapy, and then we would share these videos with the patient. We'd send it via WhatsApp or whatever medium. We would send it to the patient's phone. They would have them saved on their phone, where even when they go home, they were able to watch the videos at home, and it made it a lot easier for them. And it reduced the burden of having to remember the various different exercises and how to do them, especially when they have to do these exercises even 3 to 6 months later, when hypertrophic scarring is at its worst. So what we would often find is that their range of movement would improve significantly during their stay at hospital. And by the time they get discharged, they're able to have full range of movement. Everything is going well, but we would encourage them to continue with all of the stretches and the exercises, because we knew, especially for the full thickness burns, that 3 or 6 months later, the hypertrophic scarring would start to occur, and that would then reduce their ROM. And often, you know, it's been a very long time since they've done them, so at least they have them on their phone and they could just carry on watching these videos and refresh their memory. The videos, what made it also useful within our context is that they were easily produced in a poorly resourced context. All we needed was a smartphone, a quiet and a well-lit room. We didn't need any other resources, one person to record, and we would save the videos. And the repertoire of individual videos could be customized to the need of the patient, depending on their specific site of burn. So it was a really simple innovation. There wasn't really much to it, but it was very helpful. This idea was then disseminated in the Innovative Solutions Burn Rehabilitation Around the World book, which aimed to allow creative and innovative ideas that used local resources and turned them into patient solutions by burn therapists around the world. And very often these kind of simple ideas, they don't reach widespread production, and they often remain in silo in local areas where they could have been helpful to therapists in other cultures or other parts of the world. So yeah, as I say, it resulted in the book Innovation Solutions in Burns Rehab Around the World. And yeah, I think it just allowed other therapists during a very difficult time of COVID-19 to be able to carry on doing their work. So that is all from my side. It was just to share a simple, innovative idea, and also I hope that it allowed you all to understand a little bit more of our role as speech therapists within the management of patients with facial burns. And that's it. Thank you.
My name is Fu Anqi, the first author of this article, Comparison of the Clinical Effect of Double Eyelid Blepharoplasty with the Orbital Septum Method and the Classical Method. The corresponding author is my most respected mentor, Dr. Li Gaofeng, and also the founder of the Orbital Septum Method Double Eyelid Plastic Surgery. I come from Hunan Province, China. And I'm very honored to speak at the conference today to introduce my thesis. Next, I will explain the main aspects highlighted on the poster. Introduction. Dr. Kubuchai proposed a blepharoplasty, which removing part of the orbicularis oculi muscle in front of the tarsal plate to form an adhesion between the skin and the fascia in front of the tarsal plate. This formed a relatively stable double eyelid. This was a popular double eyelid plasty in the past, and it can be regarded as a classic method. We have used this method for more than 1 decade, but have also found some deficiencies, and this is the opportunity for us to propose the orbital septum method. Then I'll introduce about the research method. Total of 381 patients who underwent double eyelid blepharoplasty by incision in our department during 2019 were retrospective analysis. All patients were divided into two groups using the random number table method. The patients who underwent the classic method was divided into Group A, and those who underwent orbital septum surgery were defined as Group B. Both groups of operation were performed independently by the same operator. The comparison of the key step of two technology is shown on the poster, summarized as follows. In the classic surgery, we can see on the picture, we removed most of the orbicularis oculi muscles below the incision and retained the anterior facial of the tarsal plate. Then the lateral orbital septum was opened above the incision. Orbital fite was removed appropriately. Finally, sutured skin anterior facial of tarsal plate and skin then closed the incision. While in orbital septum surgery, we can see on the picture, we retain the orbicularis oculi muscle below the incision, removed the loose adipose tissue below the orbicularis oculi muscle, and retain the dense anterior tarsal facial. Then open the orbital septum, remove orbital fite appropriately, and make the orbital septum black. Next, the lower orbital septum was turned downward with the fusion of passed through a few of orbicularis oculi muscles, the lower tarsal facial, and downward overturned orbital septum, and then sutured. Finally, closed the incision by suturing in the order of skin, muscle, orbital septum, or meibomian facial, muscle, skin. Finally, I will introduce the results and conclusion. Results, we evaluate from early post-operative complications, long-term post-operative effect, scar depression, and mid-strip below the double eyelid line. These results show that compared to the classic double eyelid surgery, the orbital septum method achieves higher post-operative satisfaction. In summary, the orbital septum method emphasizes the preservation of the orbital oculi muscle, remove the loose adipose tissue below the orbicularis oculi muscles, and has the effect of preventing concavity. The orbital septum is connected to the aponeurosis of the levator palpebral and the muscle and the skin of tarsal plate anterior are connected to the orbital septum inferior. This serves to reconstruct the physiological branches of the levator superior appear to form a direct power. And we can, the last picture is the clinic. The above is my presentation. Thank you for your time.
Hello, friends. I am Dr. Anand Srivastava, Chairman and co-founder of Global Institute of Stem Cell Therapy and Research. And from bottom of my heart, I want to apologize that I could not attend this conference physically. That's what I'm sending this video. And I really thanks all the organizers of this conference who accommodated my request, because at last moment, there is some emergencies. Even after reserving my ticket, I could not make it to the conference, but I hope you will enjoy this video talk. These are a few of our international locations, and if anybody wants to visit, they are most welcome here. So today I'm going to talk about the potentials of mesenchymal stem cell based serum in the treatment of skin psoriasis. And this Global Institute of Stem Cell Therapy and Research, which is San Diego, California-based organization, We have our hospitals all around the world, including USA, Mexico, and India. I worked at several institutes of renowned institute of the world, like Japan, University of California, San Diego Medical School, University of California, Irvine, University of California, Los Angeles, the Salk Research Institute in San Diego, California, and Burnham Institute of Medical Research in San Diego, California. All this institute, I worked only on the stem cells and gene therapy. So this is what I did in my life. So let's go for the next slide. So as we know that psoriasis is a chronic autoimmune condition characterized by the rapid buildup of skin cells, leading to inflamed scaly patches. Mesenchymal stem cells have shown promise in treating psoriasis due to their immunomodulatory and anti-inflammatory properties. However, using MSC conditioned media rather than the cells themselves is an interesting approach to manage the skin psoriasis. So first we have to understand how this conditioned media may help in treatment of the psoriasis and what is the mechanism underlying that. So first, as we know that mesenchymal stem cells releases various anti-inflammatory cytokines and growth factors into their conditioned media. These molecules can suppress the inflammatory response associated with psoriasis, and therefore reducing the activation and infiltration of immune cells into the skin. Second best part of this conditioned media is immune modulation. So MSC-derived factors can modulate the activity of immune cells involved in psoriasis, such as T cells and dendritic cells. By altering their function, MSC conditioned media can dampen the abnormal immune response that contributes to the development of the psoriatic lesions. And third, it may enhance the skin regeneration. So MSC-secreted factors can stimulate the proliferation and differentiation of skin cells, including keratinocytes. This promotes the regeneration of healthy skin and aids in the repair of damaged tissue caused by psoriatic lesions. So these are the wonderful actually mechanism and things which conditioned media helps to repair the or manage the skin psoriasis. And fourth most important thing is the angiogenesis inhibition, because we know in the psoriasis there is a lot of skin regeneration. So this conditioned media has a lot of factors which inhibits the angiogenesis, thereby reduce the excessive blood flow formation seen in the psoriatic lesions and helping to normalize the skin environment. Then another property is the wound healing. That is very important for the psoriasis skin, because there is a lot of wound, continuously wound because of inflammation and all these things. So MSC secretes factors can accelerate the wound healing by promoting tissue repair and reducing scar formation. In psoriasis, where skin lesions can be excessive and chronic, these wound healing properties may help to improve overall skin health and reduce the severity of the symptoms. And then that's what we decide, that local application of this conditioned media which can be topically applied to affected area of the skin, allowing for targeted delivery of therapeutic factors directly to the psoriatic lesions. This localized treatment approach may enhance efficacy while reducing systemic exposure. So these are our own publications actually. So what we did, we collected, we have the ability to collect the conditioned media secreted by the mesenchymal stem cell in the lab. And then we gave it to patient to use who was having this psoriasis. And this is published from our institute, yes, it is my name, that is the case report in dermatological medicine. So the patient applied this for 1 month every day, and you can see he was cleared with the psoriasis. In another study, again, we have another patient actually, so who has the same psoriasis. Here you can see, and then we gave the conditioned media to him, And he applied again for 4 weeks, almost 1 month. And then it was cleared. And this we reported again a case report just recently. So these are the wonderful results. And as we know, there is no treatment of the psoriasis. So this is the best thing to do actually. And this is very safe also. There is no side effect. It is very targeted. We are not injecting any cell inside the body. That is the best part of this. So in conclusion, if you want to conclude the things, so using mesenchymal stem cell condition media instead of mesenchymal stem cell themselves may offer a safer alternatives as it eliminates the risk associated with administrating live cells. MSC condition media can be prepared as a standardized product. That is the most important thing, because there is a lot of problem in and reports coming that mesenchymal stem cell infusion in the blood has a lot of variations. So this condition media can be produced in a very standard manner, ensuring the consistency in the treatment efficacy and minimizing potential side effects. So thank you very much. Again, my friend, I am sorry that I could not make it this time, but certainly next time I'll make it. And if anybody has any question, they can write me at my email, that is anand@geostar.com, and I would certainly write back and give the answers. Again, thank you very much for hearing, and thank you all the people who organized this conference. I know it takes a lot of energy. Thank you very much, and bye.
Creating a positive and significant impact for human race is our primary goal. From research to treatment is our purpose.